Thank you, MC. The Honorable Minister of Health, Professor Isaac Adewole, the Chair of the National Tertiary Health Institution Standard Committee, the co-chair of the committee that worked on the National Surgical Opposites and Senior and Nursing Plan, all CMDs here present, and all medical directors here present, my colleague director from Federal Ministry of Health, my closer team from the Department of Health Services, all my colleague directors and head of divisions, gentlemen of the press, and our most important guest, good afternoon. Good afternoon.
Good afternoon.
Thank you, sir. Well, the Permanent Secretary will be here himself because this is one of the babies he wanted to package and give as one of the last exits give to the Honorable Minister. But he's already on an assignment outside the country, so he asked me to stand in for him. Ordinarily, I will give the vote of thanks, and I also get there. He has asked me to thank every member of the committees that handle this document, and to welcome each and every one of you for coming to grace this launching program, and to promise that he will ensure the implementation of the documents when launched. On that note, I want to, on behalf of the Permanent Secretary and the Federal Minister of Health, welcome all of you to this program. Thank you, sir.
Thank you, Director of Hospital Service. We'll have a very short video to give us a bird's eye view of why we're here. The Dean of the Business School, Rover, will take us through this moment of truth. The truth point. Just video. If we could have the shutters now brought down for this moment and the lights dimmed. Thank you.
The Honorable Minister, all protocols observed. We feel that to draw us closer to the essence of this program, we should watch a short video clip which will get us home to the issues surrounding tertiary health institutions. After that, we will now run through the basic and the anchors of the checklist and why we think and some of the strategic focus of that particular checklist. So can we have the video, please?
high mortality rates. We have maternal and child mortality rates and infant mortality rates in Nigeria. Obviously, we know that is actually even increasing rather than declining, despite all the various investments that has been done, to avert stress in Nigeria. So, in the days when we have So the end of this is to ensure that we teach ourselves what to do, how to do, and what to do. And the other is all these policy is in place. Of course, Nigeria still has provided a law in the National Health Act of 2014, where a national tertiary health institution conduct committee that put in place, and that committee has been included and already working. So we expect them, the committee, to follow up on this checklist and ensure that all that's in play of them to implement this checklist.
We just watched a video and the law, it may be part of human nature to err, like we said earlier, but it's also part of human nature to create solutions, find better alternatives, and meet the challenges ahead. The key words in the checklist is continuous. Other words have to be quality and safety, and then clinical governance, or better called accountability framework, and more important to us is a change program. Considering the checklist as a change program, we use the basic formula for change, which talks about level of dissatisfaction of the current state, which we have seen in the video. We talk about the vision of the Federal Ministry of Health for the future, and then we look at what will be our first practical step. And in any change process, we should also factor in the resistance to that particular change. So we were looking at the satisfaction level, the vision for the future, the practical steps. All these things were put together in that checklist. The satisfaction level in the health's present condition shows that there is unprecedented attention to health outcomes. What you saw earlier, I will call it the war of words, the war of values rather. And then we also look at the importance of healing without harm. And the level of dissatisfaction leads us to the imperative for change in what we are doing in our present hospital state. The vision of the Federal Ministry of Health was very clear, and the Director of Hospital Services made it very clear that there is need for continuously increasing the quality and safety of the services we have in our hospitals. The checklist also considered the issue of trust and confidence in our hospitals. And also we looked at possibilities of increasing uptake and possibilities of increasing utilization, and more importantly, reducing medical tourism. When we now look at the next factor, which is what are the first practical steps? One of the first practical steps we considered was the issue of developing a checklist. The Ministry of Health considered that one of the change factors is to develop a checklist. That checklist will be guided by clinical governance, which brings into certain factors like education and training, clinical audits, clinical effectiveness, talked about research, talked about openness, using the blame factor, and also risk management in our hospitals. The checklist also provides the direction, provides support, and provides the accountability framework. The checklist will also focus on management of resources, it will focus on leadership and staff engagement, it will focus on attitude of caregivers, and more importantly, we talk about ergonomics, which is the relationship between humans and then the use of equipment. We should also look at system integration. The checklists also have been designed to recognize certain factors. One, it is made to be very simple and clear. The checklist is also designed to be a snapshot report format, and then it should leverage on performance and leverage on change efforts of the institution. The considerations in designing the checklist. One is that quality is a philosophy. We should look at quality as a philosophy. The second point is that quality is dynamic and quality is a continuum. The third point in designing this is that the value of simplicity, because medicine is really complex, so we try to look at the value of simplicity. The fourth one is that quality is a collective responsibility. And in the design, we recognize also that the hospital is a complex, adaptive system. Other considerations is that hospitals should be looked at as a learning organization. We should think about leadership, patient engagement, leadership and patient engagement, and the last in the consideration really is that quality can be what? Improved. In the design of this, these focus areas were general outpatients, talk about surgical operations, accident and emergency, intensive care, laboratory medicine, pharmaceutical services, and radiology, and also looked at dental and then intensive and inpatient care. Implementation is very, very important. In any strategy, the key part of it is the execution. So in implementing this, we say that it should be frequent and accurate assessment and timely feedback. More importantly, timely feedbacks. The next level is that we should be able to compare results to what expectations and then determine the needs for action. We cannot say change without resistance. So in discussing the resistance platform, we are looking at the conflict of interest. When we present this checklist, we are bound to find out the conflict of interest. So how do we handle those conflicts of interest? There should be organizational. We've also realized that there's need to think of how we dislodge the cultural sclerosis in our hospital systems. We also think about how the issue of sunk cost, which means that the functions and the things that we already have in our system, are we going to wish them away and realign? And also the issue of mindset. I call that cognitive limitations of the operators. And more importantly, we also have to think about the workflow process. So the issue of quality in closing is complex, and the stakes in quality, they are too high, especially in an organization or especially in a country where performance orientation is important and cost-conscious environment. I'll close with this. Quality is never an accident. It is always the result of high intention, sincere efforts, intelligent direction, and skillful execution. Quality, it represents a wise choice of many alternatives. So this checklist will create what we call a new context for engagement and a new context for change. Thank you very much.
Another round of applause for the Dean Robert Business School, Adewole. We'd like to have another short overview, please, very, very short, from Professor Ahmed, the co-chair of the National Surgical Obstetrics and Anesthesia Nursing Plan Committee. Thank you. Can you support it? Yes, please, because of time.
The slide, please. Honorable Minister, sir, all protocols observed. So we worked on the National Surgical Obstetrics anesthesia and nursing plan. But just to give a short background about what led to this. In the last few years, worldwide, what has been found is that about 30% of the entire global burden of diseases are conditions that are amenable to surgical care. Before now, surgical care was thought to be a little bit too expensive and perhaps not very cost effective. And we worked with the Lancet Commission on Global Surgery in 2015, and we found a staggering number. 5 billion of the world's 7.7 billion people have no access to safe and timely surgical care with financial risk protection. And more than 80% of these 5 billion are in countries like ours. We decided to go further, and we found that of these 1.7 billion children, and almost 50% of our population are children. They have no access to safe and timely emergency and essential surgical care. It was also found that if you take injury, for instance, it causes a lot more mortalities compared to many of the communicable diseases. Yet there has not been significant focus on them. And it was also found that many families are thrown into poverty just because of a cesarean section or a simple hernia repair. The family goes into poverty. And you can imagine how many of our families are doing that. Our slide has said. No? Okay. Sorry. Right. So with this background, the World Health Organization determined that it would be impossible to achieve universal health coverage and the SDGs without investing in surgical care. So with that, Nigeria worked along with a number of other countries, and in May 2015, the World Health Assembly passed a resolution mandating countries to include emergency and essential surgical care in their universal health coverage. Now that prompted several countries to begin to embark on creating a national surgical obstetrics and anesthesia plan. Now these are the targets set by the World Health Assembly for countries to achieve by 2030. 80% of the country should have access within 2 hours to a center that can provide emergency surgical care. Each country to have 20 surgeons, anesthetists, and obstetricians. And each country should be doing at least 5,000 surgical procedures per 100,000 every year. Each country to be all hospitals to be reporting their perioperative mortality by 2030. And I think more importantly is that every citizen, every individual in every country by 2030 should be protected against catastrophic expenditure or poverty just because of a surgical procedure.
Well, thank you, Doctor, for your cooperation and support. Congratulations. Thank you. I thought the applause will encourage the BP to come back there. We'd like to invite the President, please, Mr. President of the National Postgraduate College, when you come, when you leave, after your delivery, we'd like you to just sit by the Honorable Minister of Health. Just right in there. Thank you. Yes. Let's have this one.
Honorable Minister, sir, distinguished ladies and gentlemen, let me also observe the existing protocol. The National Postgraduate Medical College, which by law is saddled with the training of specialists in clinical medicine for Nigeria, was informed of this project on the National Surgical Obstetric anesthesia and nursing plan for Nigeria. And we thought that we thought and saw it as part of a core mandate, and decided that we will be truly very involved in it. And in that process, we tried our best to see that the study is, the plan was worked out and is a success. Other countries have launched theirs, and we thought there was no point in waiting. And we are glad today that we are at the point where this has come to this situation. The college has played and continues to play a role in training of manpower that will meet the objectives of the surgical obstetric and anesthesia plan. Because without this trained, specialized manpower, the delivery of meeting the objectives of the SDGs and the plan of the federal government will not be realized. And we continue to position ourselves as a college to take part in research, to continue to update whatever is going on in the areas of clinical health and clinical service delivery. We, as the college, continue to work very closely with the teaching hospitals, because these teaching hospitals and chief medical directors that head them are our partners, and they continue to be the laboratory from which we get our results and train our people. And on the way forward, we are looking forward to the implementation of the residency training bill which has been signed, which will give a robust training to our specialists. So in all, the college continues to position itself and will readily assist and to see that this National Surgical Obstetric and Anesthesia and Nursing Plan comes to fruition and places the head of the nation in a better footing. On that note, I congratulate the Honorable Minister for carrying out, for seeing this process through. I congratulate the Minister of Health, the Federal Ministry of Health, and of course the Director of Hospital Services, who tirelessly saw through this process. On that note, I say congratulations and thank you, and we hope that this sees us into the next level of good health for Nigerians. Thank you.
President, West African College of Surgeons, 1 minute. Professor Ezeoma, please, 1 minute.
The Honorable Minister of Health, all protocols duly observed. I bring you felicitations from the President of the West African College of Surgeons and the Council. I want to inform you that the college is really very delighted to be here today. The two things being launched today are very dear to our hearts. The checklist talks of quality and assessment. And as an accrediting institution and credentialing institution, we are very proud to be there. This document will be studied very closely by a college, because whatever is in that document will help us in fulfilling our own mandate. Now, the surgical obstetric anesthesia and nursing plan is fundamental to our own strategic plan, and that's why we partnered with the National College to be able to edit it. So we congratulate you for this wonderful work and continue to be part and parcel of manpower development. Thank you for listening.
Dr. Mohamed, Chairman of Chairman. A round of applause for our chair.
Honorable Minister, sir,
distinguished ladies and gentlemen, I'm going to say a little about the checklist that is being launched today. I'm a member of representing the committee as well on the National Committee for Standards. And we've been talking about minimum standards since the past 2 years we have started meeting. And I actually, on behalf of the committee, requested that let's have this minimum standard so that we know what you are coming to check. And I was delighted when I was shown a copy some few months ago of the final stages of the editing. And I put it to my colleagues and I said, have your say now or forever hold your peace. Because it is coming and it is coming and it is here now. So I'm so happy. We've had some form of quality assessments and in the laboratory for some years now because of international support. Many hospitals participated in that, including National Hospital. And from my own experience at National Hospital, when this was done about 5 years ago, it took 2 years to move from 1 star to 4 or 5 star. 2 years. So the checklist was there, no problem. The minimum standards were there, but people had to be mentored to develop quality manuals because this was new to many people. And then people had to be mentored to also develop SOPs and standards and protocols against which this checklist will be applied. And so the first assessment that was done at the National Hospital, the 4 labs all had 1 star out of 5. When you finish the assessment, you now score them, developed by WHO, their checklist. You now score, and it was 1 star, and I wasn't discouraged. I said, well, it's a good way to start. Somebody, myself, who have been trained by WHO on quality check and mentoring. I said, we are going to improve if we have money. We started sending people for training on the quality manual and the checklist. And at the next assessment, 3 of the 4 labs had 2 star, and 1 lab had 3 star. At the exit assessment, 18 months later, 1 lab had 4 over 5 star, and the other 3 labs had 3 over 5 star. Okay? So what this means to me and what I'm trying to say to the chairman of the committee and to Director of Hospital Services and Honorable Minister is this checklist needs to be funded, backed by mentors. And also there is a need because checklist is like walking from the questions to the syllabus. You are going to do an exam, this is the questions. The checklist is the questions you will be asked. But there need to be a syllabus and a content. Okay? So with the checklist, it will help you to know, if you get the question paper to an exam, you should know what textbook to go and read. So that's why I told my colleagues that it is good we are even starting this way. Because you would then not say, I don't know what I should do. With this checklist, in each department, in A&E and so on, sorry, I'm not preempting the launching, but because I've seen it and on behalf, I'm reassuring my colleagues that you then know what you need to place in A&E. You need to know what you need to have in theater. And I had to join a group to check 2 hospitals on Saturday on behalf of the Honorable Minister, preparing for emergency services during presidential inauguration. And then we were sent a checklist, very comprehensive checklist, even more comprehensive than even this one. And I thought this one is a bit lenient when I saw this new one. And I said to myself, which hospital can have all these things? But by the time we checked, for instance, we had to even check the ambulances. And when we checked the ambulance, 1 ambulance in these 2 hospitals met with more than 90%, surprisingly, of what was required. So some of these things we already have.
But the problem we lack is documentation, evaluation, re-evaluation, and documentation. Thank you very much. I hope that this will do justice to the problem. Thank you.
Thank you, Mr. Chairman. Can we give the chairman clap? Something that looks more like a chairman kind of thing. Your Excellencies, ladies and gentlemen, the time has come for us to listen to General Superintendent of the Health Sector speak to us. Keynote address in launching documents for our beloved country. No other person than our Honorable Minister of Health, Professor Isaac Adewole. Minister, sir. A resounding clap, please. Let's keep it like this.
Thank you, Basi. The Permanent Secretary, ably represented, the DG of the Bureau of Public Service Reform, Mr. Dasuki Ibrahim Arabi, the Chief Celebrant for today, Dr. Oji Amedu, is full of smiles. Fellow directors from the Federal Ministry of Health, those who will take the exams, because this is going to be an exam, the same dish, and the medical directors. I'm sure they are worried, what will this entail? The presidents of the postgraduate colleges, particularly National College, and then West African College represented, and of course, the chair of this new exam body, National Tertiary Institution Standard Committee, Professor Lesson. Distinguished ladies and gentlemen, let me thank the Dean of the Rover Institute for taking us through those slides. I want to commend you, very detailed. And there are also lessons for many of us. This program was scheduled to start at 11. Unfortunately, we were at the National Assembly. And what we went there to do had to do with issue of standards and quality. And so I see this program as an extension of the other one. And on behalf of Dr. Amedu, I want to apologize for keeping you waiting. But woe unto you if you are called by National Assembly and you are not there. You know the implications. They might even threaten to arrest you. Let me especially recognize my CMD. My CMD is there. And that has implication when your CMD is sitting. It shows that I'm a product of an institution. So thank you, CMD, for being here. You of USAID came up at that meeting, and I spoke on your behalf, that there's a new leadership in USAID, and working together with all USAID around. So that was a commitment I gave on your behalf. And we must meet that pledge and put things right in usage. Zaria was also mentioned, but Zaria, as of today, does not have a CMD. We are hoping that the CMD will mark very soon for Zaria. So Zaria and Enugu were elected. Let me add a few things to what the DG mentioned. One, the evaluation must be impartial. Two, there must be a reward system. Anytime you do evaluation, you must reward. We started this process over 2 years ago, DG. I'm sure even though it was started by your predecessor, but there are certain things there. We offered the Ministry of Health as a template for this assessment, and we are still committed to it. And we believe that there are many things we need to reform in the health sector. And we will partner with you. You've done the initial one by looking at how long does it take to get to be seen by a doctor in any of our facilities. And that is worrisome when that result was presented. And we felt that that should not happen. We should see quality as a fundamental human right, not just as a tool, not as a system, not as what we call a collective, not as a process, but we should see it as a right to which every Nigerian is entitled to enjoy. And if we have that in mind, I think we will change the way and manner in which you do business. The other thing has to be productivity. I visited the largest hospital in India, Safdarjung. Safdarjung has over 3,000 beds. I went to the Obs and Gynae department for obvious reasons. 31 consultants. They conduct 28,000 deliveries every year and do 20 scissors daily in Safdarjung in India. So that means for scissor, it's like a conveyor belt. Because for you to do, and in 2 theaters, 20 scissors every day. So CMD, we have 2 theaters in usage, O&G department. We should be able to do 20 scissors. Although we have only 22 consultants. But even we can't do 20, maybe 12, maybe 14. But 28,000 deliveries every year. So we must look at productivity. And lastly, the environment. Nigerians love quality, let's be honest. Even the uneducated, they love quality. And we know what is of quality, even if we can't define it. We know quality when we see it. When we enjoy it, when we are offered quality, we know it. One of my aides told me a story this morning. He went to a shop and someone looked at his wristwatch and said, this is not of good quality. So we know quality. So when people look at shoes, they know quality. So in healthcare, we know quality. And that is the real challenge for our CMDs, our chief executives. We must put things right. And we don't have a choice. The searchlight is on us. And it's even more serious simply because the secondary care system is underperforming. There is a huge demand on you. I could remember a time in Ibadan, and I'm sure Professor Lisami will remember, patients will sing not to be referred to usage. They will be praying in the morning. I don't know if you can still remember, they sing in Yoruba, Yorokun, Adeole Ubese, or Orita Mefa, Mama, Yoruba mi. That was them. Now they themselves will run. I think someone sent me a bus and said the bus was going to Mushin and the conductor mistakenly said London. And we were rushing to the bus. Now, people will rush into a bus going to usage. Because the Adewole they were singing praises about is no longer functioning optimally. So that's the challenge you face. You can't enter usage in those days, like I said this morning, without a referral letter. Now, nobody will ask you for the referral letter. In those days, they will send you back or send you to family clinic or OPD to be tried. And someone will say, this is not serious, go away. That won't happen now. Even headaches, skin rash of 1 year ago, we enter usage. So we need to improve on the environment. We need to look at quality. And of course, the reward system should include remuneration. It's something that some people don't want to say, but we must talk about it. people must be compensated if we want them to give their best in a way that they will not think of the second option. So the usual remuneration must come in, and when we put all this together, we will have a health system that will serve us well. And we're also reminded, I've heard of that story before, that in the past, the princess and the prince in Saudi Arabia came to UCA for treatment. CMD. I hope that will happen one day. Let me really appreciate Dr. Amedu and Professor Elesami for pushing through with the checklist. We cannot have a perfect checklist, but we must start from somewhere. And that is why the checklist has to be put on, but let us start. I want to thank all those who, when I saw it, I couldn't believe it. And I had to commend him for really working quietly to get it done. I also want to thank somebody here I think I met her once, but we've been communicating for a long time. She has refused to give up on me. That is Dr. Bisola Onoji Obembe. Where is she? I hope I can recognize her if I see her somewhere. She's not here. Yes. She's very persistent. She will send mails. She won't give up. I'm not sure I can recognize her. I must have met her once. But emails, and then the entire writing committee, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. May I ask you to stand up so that we can publicly commend you with Dr. Amedu as chair, Professor Ame as co-chair, and the rest of the members. Professor Karia, Professor Bosia, Owe Juna, Onoji Obembe, Comrade Lawal. There's even a comrade there. That is comrade. Where are you? Oh, comrade. The lady is a comrade. Oh my God! I'm also a comrade. And then we have Omolara Williams, Justina Olajide. We have Omolara Faboya. We have Abraham Bethel Kasimu and Elizabeth Pabi. Publicly on behalf of all of us, including those who are not here, and those who will benefit from your work, I want to say thank you. And I hope the document has their names listed there. And I think we should also encourage scholarship as much as possible. So thank you for the work you've done. I think what is left is for me to publicly launch the document. Where are they? We need to come down
yes,
there.
Honorable Minister, with your top France list, you join the Honorable Minister. Dr. Medu will lead the team. Join. It will be an unveiling ceremony. We'll just unveil. Please, could you come to this place? Spots the
So we unmask the masquerade.
Yes. Please come.
There is still room on this side.
Thanks. One person, please go.
The launching of the document has actually marked the beginning of serious work for the Obembe committee. Because part of what the committee should do is to contribute to the budgeting exercises. So that you will tell us what do we need to fund these institutions properly. Because it is not enough to go there and be assessing them. We must provide resources. But we will now seek for resources based on the objective assessment of the need. So that's why your job is a serious one. Because now you give us guidance. And then we move away from doing outreach programs in their budgeting and budget for proper items. So I think on behalf of all of us, we have the singular honor of
a standing ovation, please.
unveiling the document to the glory of God. and for the improvement of the healthcare system in Nigeria. And may all who work into our facilities find favor. And may those who work there also find favor.
Amen.
We commission the documents in the name of God the Father, the Son, and the Holy Spirit. Thank you.
Thank you, Honorable Minister for Health, Professor Isaac Adewole. Please, you want to take some paparazzis briefly? Just to inform that we have come to the end of this occasion, and we should congratulate ourselves for this. After the vote of thanks by the Director of Hospital Services, we need to inform that lunch is served at the restaurant on the left end. Restaurant by the left, please. By the left. We shouldn't miss it. It's been there and it's already served.
We're always working for you.
Congratulations.
Yes, thank you.
Thank you. We'll take photo shots after this.
As we go back, I wish you all safe journeys. Thank you very much.
A round of applause. Thank you. Thank you again for coming. See you in implementation and monitoring stage.
Please make sure the CM is taking a copy from this table. CM these registers. Take a copy from this table when you go there.
My name is Daniel and I work with Prof College and I'm one of the people who work on the checklist, and the Honorable Minister was here and it was a good time out. A lot of people were here and good things, moving health forward. It's a good thing to know that there are other checklists, there are things hidden that we actually did not know until now, and it was moving. So everyone, all base to the levels, the ministers and the Prof College team. Guys,